Good evening and welcome to today's program. The program will begin in just a few minutes. In the meantime, we invite everyone to complete the brief pre-test shown on your screen. Your participation in this pre-test is invaluable in helping us measure the effectiveness of this program. Again, the program will begin in just a few minutes. Welcome and thank you for your participation. Good evening and welcome to tonight's program entitled Steroids, Surgery, or Biologics, evaluating the options on the path to individualized management of chronic rhinosinusitis with nasal polyps. I'll turn the program over to our faculty momentarily, but first I'd like to review a few brief housekeeping notes. If you have not yet completed the pre-test shown on your screen, we'll leave it open for approximately 2 more minutes for you to complete now. Tonight's program is certified for 1.25 AMA Category 1 credits. To receive credit, please complete the post-test and evaluation form following the program at www.integrityce.com/AAOA post-eval. We will have a variety of case videos and polling questions during this program. When polling questions appear, please select your answer and be sure to hit submit to enter your response. There will be a question and answer session at the end of tonight's program. Please hold all questions until that time. A box will appear to enter your questions at the summary slide. And with that, I'm very happy to turn the program over to Dr. Naclerio to begin. Thank you.
Good evening. And I too would like to welcome you to our program entitled Steroids, Surgery, or Biologics. And I think it's particularly important that there is a question mark after biologics. And what we are going to be is evaluating the options on the path to individualized management of chronic rhinosinusitis with nasal polyps. It is an exciting time in the management of chronic rhinosinusitis with nasal polyps. For years, we've followed a basic routine that takes care of the vast majority of patients, but we've all come to have patients who we can no longer manage well and control their disease. But over the last decade, the pathophysiology and of the inflammatory process has been worked on. And now we have the introduction of biologics, which can interfere with some of those inflammatory processes. And to perform this program tonight, I am joined by 2 other faculty members, Cecilia Damask from the University of Central Florida, and Christine B. Franzese from the University of Missouri at Columbia. And I am Bob Naclerio, and I am currently at the Johns Hopkins University. On this slide, you can see our disclosures for each of the faculty members. And so what we hope to accomplish tonight in our learning objectives are 1, to identify the phenotypes and endotypes of chronic rhinosinusitis with and without nasal polyps based on what is understood thus far about immunological pathophysiology and its impact on disease burden. We summarize the inflammatory targets of biological treatments for chronic rhinosinusitis with nasal polyps and their efficacy and safety profiles reported in clinical trials. And then we'd like to implement appropriate selection criteria for the patients with chronic rhinosinusitis with nasal polyps who might benefit from treatment with targeted biologics over steroids or surgery. At this point, I'd like to pass off the baton to Christine Franz, who will begin the academic part of our program.
Thank you so much. And I'd like to welcome you as well. So we're going to start with a little bit of the basics, an overview of this disorder, and give you an idea of the scope of the problem. So looking at epidemiology just of chronic rhinosinusitis to begin with. So according to the CDC, 28.9 million, almost all getting close to 30 million Americans have been diagnosed with chronic rhinosinusitis over the age of 18. Now, looking at roughly phenotypes, there's essentially two major types. So there's chronic rhinosinusitis with polyps and chronic rhinosinusitis without polyps. So overall, with this number of adult Americans affected, that's almost 12% of the population. And when you break it down, about 20% of those people that are affected will have chronic rhinosinusitis with nasal polyps, while the rest of them will have the phenotype that is without polyps. This the breakdown is also a little bit interesting because the phenotype with polyps tends to be a little bit more male, and those without polyps tend to be a little bit more female. When we get down to the disease burden, many of you are familiar with these diagnostic criteria already. So we're looking for these 4 key symptoms. Usually we want 2 or more for at least 12 weeks. And we're looking for nasal obstruction or congestion. Usually it's bilateral. Rhinorrhea or postnasal drip, decrease or loss of sense of smell, although in this pandemic area, that may be a little challenging. Facial pain and pressure. Nasal polyps, though, impact a lot of the patient's quality of life. And I think one of the ones we don't appreciate as much as probably we should, or at least we're learning to appreciate more, is the impact on sleep. Particularly when you're not able to breathe through your nose, it really disrupts the quality of your sleep. Many of these patients have to sleep in recliners. It results in a lot of daytime fatigue, loss of work productivity, and particularly if your polyps are very large, your nasal drainage doesn't go down the back of your throat. It can come out of the front of your throat. So for example, like I had one patient with extremely large polyps who had to walk around with a handkerchief constantly. So it was a big social embarrassment, social anxiety for him. And then you'll see our lovely images to the side here. We have our control CT scan in a normal patient, and then the CT scan in someone that has nasal polyps, and then our endoscopy, which most people are familiar with, the control side, which looks like a normal right nasal cavity. And then we have here a right nasal cavity with nasal polyps. So as far as the disease burden, although there's about 12% of the population affected, it's one of the top 10 most costly conditions. So close to almost $10 billion in direct care costs. So while this is a fraction of the population, these patients are medically intensive on our healthcare system. They incur higher annual costs, particularly for nasal polyps over chronic rhinosinusitis without nasal polyps, and $13 billion in indirect costs. So it's quite a substantial burden on the economy. If you can see the last line, $22 to $60 billion overall, an economic burden. So this is a disease that has a lot of direct and indirect costs to our healthcare system, and treating it is actually quite important. All this, though, now that we have this background information, it seems a little bit impersonal, and I think digging into some patient cases would be very helpful. So, Dr. Damask, can you help us out with that?
Sure. So I'm happy to start off with something fun, like a clinical case, and we're going to hear the story about Brandon, who's a 38-year-old male.
Hi, I'm Brandon. I'm 38. I don't know why, but my nose has been stuffed up and runny all year long. This has been going on for a few years, but has gotten much worse in the last year. Sometimes I have a hard time sleeping. From the congestion, and once in a while I'll wake up with a sore throat. I keep feeling like I have to clear my throat, or I've been dry coughing a lot, and the coughing seems to be worse at night. I've been using a nasal spray, Flonase, I think, and allergy medicine from the grocery store for the last few years. They helped for a long time, but don't really do anything anymore. I tried a sinus flush with salt water, but that never really seemed to do anything. About 6 months ago, I realized I couldn't smell anything and food didn't taste the same. And I thought, maybe I have coronavirus. So I got tested a couple times, but both times the test said I didn't have it. I went to see my family doctor, and she said she thought it was allergies. She prescribed a round of oral steroids, and she recommended that I consult with a specialist and to continue using the nasal spray. The oral steroids provided some relief, but I never followed up with the specialist. The congestion returned shortly after, which brings me here today. Aside from that one visit, I've never been told that I have allergies or asthma, and no one in my family has either. I just want to be able to breathe from my nose again.
Okay, so want to make sure to kind of highlight some of the salient points. I mean, definitely we hear that this is something that is very distressing to the patient. It is affecting his sleep, affecting the quality of his life. And important things that I hear out of the case is that there is no family history of any allergy and no personal history of any allergy. Patient has tried topical nasal steroid sprays and oral antihistamines over the counter without improvement. He complains of nasal congestion. He complained of loss of sense of smell. He also relates that he's been on a burst of steroids and things seemed to get better when he was on prednisone. He had improvement in his smell and in his nasal congestion, but shortly thereafter, once off the steroids, symptomatology started to return. Other things that you might want to know if you're seeing the patient in the office is you obviously would do a physical exam, but not really getting a whole lot of information off of our physical exam. He has some mucus visible in the back of his throat, and he has a lot of nasal congestion. So when you try to look in his nose with anterior rhinoscopy, all you kind of really see are really big turbinates that are swollen and some clear secretions. So what I would like to know is, what would you all suggest? So the patient has tried some topical nasal steroid spray, said he really didn't get much relief with it. And you, as the otolaryngologist, what would you like to do to try to figure out what is going on with this patient so that you could hopefully help him? So interested to see what the audience thinks that they would like to do. So we're getting some good responses in, and I think that we will close out the poll. And Dr. Naclerio and Dr. Franzese, what do you think of a group of otolaryngologists wanting to do nasal endoscopy? Sounds pretty reasonable, I think.
I'm shocked, Dr. Damask.
So I unfortunately do not have any endoscopy pictures to show you, but as we are talking about CRS with NP, I can imagine that our patient probably had some big bulky polyps on endoscopy, and we want to think a little bit more about what really makes up our criteria for diagnosis. And as Christine went over with you some of the cardinal symptoms associated with CRS with NP, we want at least 2 of those 4 cardinal symptoms to be present for at least 12 weeks. And again, that's nasal obstruction or congestion, diminished or loss of sense of smell, nasal discharge, and facial pain or pressure. And then you want to have at least 1 objective criteria. And I think for most of us, we typically would do nasal endoscopy to look for nasal polyposis, but CT scan could be an alternative to see if there's something like that. And traditionally, like when we look at ICAR and look at recommendations for treatment for nasal polyps, we know that ICAR does definitely recommend doing saline irrigation followed by topical therapy like a nasal steroid spray or a rinse or something of the type, and that potentially a short course of oral corticosteroids could help improve symptomatology. And then, optional things included different types of antibiotics, potentially something like a macrolide. And then for failures, consider doing surgical intervention. This is an algorithm that kind of spells out similar to what ICAR recommended, to start potentially with a nasal steroid spray for our CRS with NP patients. And if their symptomatology is controlled with topical steroids, then continue with them. Whereas if symptomatology was not controlled, could consider doing a burst of systemic oral corticosteroids. And then if they had response, had them continue with their topical nasal steroids. If they had no response with systemic steroids, then you might want to look at doing planning for surgery by starting with CT imaging. And ICAR basically highlights the importance of saline irrigation, topical steroids, and does say that oral steroids are of benefit, but really cautions that it might be only one short course potentially in a year, because we do see some potential side effects associated with steroids. And Dr. Franzese is going to talk with us next about steroids.
So, as otolaryngologists, we see these patients and they do actually respond very well to steroids. We're not alone in our steroid use. Pulmonologists, allergists, immunologists, dermatologists, all of these are fields that are known for high utilization of oral corticosteroids. But we've come to understand recently that there are both short-term and long-term risks. Now, there are many studies in the literature looking at the long-term risks for oral corticosteroids. This is one particular one, though, that's very interesting because of how large it is. So this looked at patients, almost 25,000 patients in matched pairs of asthmatics who had some exposure during their lifetime over this 25-year study to oral corticosteroids, and those who had no exposure. And when you looked at their odds ratios for different risk factors, it was very impressive how not just the amount of risk that increased, but also the different types of risk. And this is just a small selection of some of the risks, everything where you would sort of expect from osteoporosis and fractures to other things like sleep apnea, renal impairment, psychiatric disorders. All of these risks were elevated. And the interesting thing about this study was it demonstrated a dose response relationship, so that the more steroids you got, the worse risk you had. And in fact, you began to have an elevated risk with as little as just 500 milligrams or half a gram. So when you think about what we use for a burst of oral steroids, let's say you give someone 50 milligrams of prednisone for 6 days, already there's 300 milligrams. You're getting very close to that 500 milligram threshold, that half a gram. One more burst puts them over, and for that patient, for their lifetime exposure, you've really altered their risk factors. So it's something we need to think very strongly about before we use these medications. So let's go over another case study.
Hi, I'm Jennifer, and I'm 50 years old. I've been struggling with sinus infections and congestion for the past year. My nose feels stuffed up all the time, and I feel this achiness and pressure behind my eyes and cheekbone. I've had year-round allergies since I was a teenager, and I used to get sinus infections occasionally, about once a year. My doctors always prescribed antibiotics, and they always went away after 2 or 3 days. Lately, I've been getting these infections more frequently. I also have asthma that I take an inhaler for every day. The infections seem to make it worse, and I've had to use a rescue inhaler a few times. The last time I had a sinus infection, about 6 weeks ago, the antibiotic helped a little, but not enough. So my doctor prescribed a nasal steroid spray. I've been using it every day as instructed, but it doesn't seem to help at all. I've had to call out sick from work several times, and some of my coworkers have complained about having to cover for me. I took a couple rounds of oral steroids over the past year, which really helped, but I found out it's not safe to take them for a long time. My doctor says he thinks I might have nasal polyps and referred me to an ear, nose, and throat specialist. I hope she can figure out what's causing the congestion and frequent sinus infections.
So similar to the first case, let's hit the salient high points. So this is a patient that has asthma, and she's had asthma since the age of 22. And one of the key things she mentions is she notes when she has a flare in her sinonasal symptoms that her asthma tends to get worse, and she relies a lot more on her rescue inhaler. So she also has a history of allergies, but this seems to be different from that, although she has a long history of parental allergies since the age of 16. So currently she's taking fluticasone, she's on a mometasone nasal spray, and she has her albuterol inhaler as needed. You also note that she's been given antibiotics for these exacerbations quite a few times. She just had some antibiotics about 6 weeks ago, but it didn't seem to be a difference. And most notably here, she's had 2 rounds of oral corticosteroids. She doesn't say how much she has, but generally these bursts tend to be anywhere from 3 days to sometimes up to 2 weeks. So you sort of wonder, has she already gone over her lifetime risk for oral corticosteroids? Looking at her physical exam, so she's 5'6", 155 pounds. She's a little bit hypertensive. Her heart rate's good. And then similar to the first case, we're going to take a look at her physical exam, and our notable findings are that her sinuses are sensitive to palpation. And when you do nasal endoscopy, we do see some large nasal polyps. So now we'd like to ask the audience a polling question. So based on what you know on Jennifer's medical history, what do you think her underlying endotype is? Type 1, type 2, or type 3? And it's okay if you don't know, because we'll go over that. So, and this is something where we're really starting to look at to see if we can further go from phenotypes, which is a more rudimentary categorization, to different endotypes and what they might mean to us. So, okay, so I see a strong type 2 predominance here, and that would be very consistent with nasal polyps. So if we could go ahead and have our slides back. Excellent, thank you. So here's a brief review of the 3 inflammatory endotypes that we have come to understand thus far. So we have type 1 and type 3. In our Western population, these are less dominant, with the type 2 being the most prevalent. You can see there's different effector cells, and we'll touch on the type 2 effector cells a little more. You'll also know there's some overlap. The cytokines between each ones are different, with the type 2 cytokines being primarily being driven by IL-4, IL-5, and IL-13. You'll notice that type 1 tends to have more of an infectious look with purulent nasal discharge. It's more commonly seen without polyps, and that has that higher female to male distribution, although type 3 also will have purulent discharge, whether it has polyps or not. And then the type 2 inflammation is most strongly associated with nasal polyps, but we'll also see that particular inflammatory endotype in asthma and other disorders. So with this type 2, type 1, type 3, there tends to be some overlaps. So these delineations are generally valid, but recent evidence has shown that, like anything, there's like no easy, simple, straightforward answer. There tends to be some mixed endotypes. About 50% or more patients will have some type 2 inflammation, so that seems to be the primary driver. And 26% of Western CRS patients with nasal polyps have a mixed pattern, though. So they may have a bit of type 1 inflammation in their pattern. The interesting thing is, again, like I said, there's a lot of crossover in these cellular mechanisms. So eosinophils are not necessarily exclusive to type 2 chronic rhinosinusitis with nasal polyps. You will also see eosinophils involved in chronic rhinosinusitis without nasal polyps, and neutrophils as well. Is this only in type 1 disease without nasal polyps? No, you can find neutrophils in patients with nasal polyps. So it's not as nice and simple and classified rigidly as we would like it to. Like anything in nature, it tends to be a little bit messy. our understanding of this inflammatory cascade has also improved over time. So when we start on the left of this slide, of course, we'll start with the epithelial barrier. And here we see when we have dysfunction and breakdown of the epithelial barrier, we trigger these chemicals, these cytokines in our organs called alarmins. So thymostromic lymphopoietin, IL-25, IL-33. Now, in the past, we really thought more about an allergic process, but we've come to understand that other things, viral particles, irritants, pollutants, bacteria, and endotoxins can actually trigger this cascade too. It will involve the IL type, innate lymphoid type 2 cells, as well as type 2 helper cells. And you'll see up the top is an allergic pathway, but this is really can be activated by non-allergic things. It is dominated by IL-4, 5, and 13, although other cytokines will come into play here. But you'll see IL-4 is the main cytokine that will activate B cells and involve them in something called isotype switching, where they'll switch from their native, naive immunoglobulin they're expressing on the cell surface to specifically switch to produce IgE. So you'll see that expressed on the diagram. It's secreted and then taken up by other cells and put on their surface by high affinity IgE receptors. You'll see IL-5 in the middle there. So IL-5 is, as like it says to the eosinophils, live long and prosper. It really increases the differentiation and survival of eosinophils. And then IL-4, 5, and 13 are very important to trafficking these eosinophils into different body organs and tissues. And then IL-13, that has that beautiful effect of fibrosis and muscle hypertrophy, as well as mucus hypersecretion, which everybody loves, mucus hypersecretion. So Jennifer is coming to see you. So she's coming, she has followed up with a recommendation to see an otolaryngologist. She's never had any kind of surgery before. You can see these juicy, beautiful nasal polyps on endoscopy. Her CAT scan of her sinuses also shows nasal polyposis and pansinusitis, as you would expect, but there's no evidence of fungal chronic rhinosinusitis. You don't see any mucoceles or other concerning artifacts. You do get an FEV1, and it's 70%, which is not surprising since she is an asthmatic. She has some mildly elevated blood eosinophil levels at 302. Her total IgE is mildly elevated at 202. And she has this confirmed diagnosis of comorbid asthma. So Dr. Naclerio, let's kind of head down that asthma route. What do you think of that? Oh, you're muted.
I think it's very important about asthma. I think that was the clue that everyone jumped on to get the type 2 inflammation going. And so none of us as clinicians, look in there and see IL-5 or IL-4 or 13 in these endotypes, though they've been very instrumental and important. I thought I would share with you this slide, which comes from the Galen study in Europe. And they had 3 groups of patients: those that were a reference group, chronic rhinosinusitis with nasal polyps, chronic rhinosinusitis without polyps. And you can see, if you go to the far left, and you can see that allergic rhinitis, and lots of people have allergic rhinitis, but it's no different between the group that has polyps, chronic rhinosinusitis with or without polyps. You get to atopy, where you actually measure IgE levels. You begin to see separation with elevation in that. But you see the biggest differentiator there is asthma. And you can see that when you get to those with chronic sinusitis with nasal polyps, asthma plays a large role. And so if you see somebody in the clinic with nasal polyps, you should definitely be asking them about their lung function and activity period. Then there's this subgroup, which used to be known as aspirin exacerbated respiratory disease. It involves more than aspirin, and the nonsteroidals are involved. And you can see that is elevated, aspirin sensitivity is elevated in people with chronic rhinosinusitis with nasal polyps. Other factors like eczema, which is a type 2 disease. Drug allergy, you can see, can also be a type 2 disease, and it seems to go along with people with that, but it's not of the frequency of asthma. So let me turn it back to you, Christine.
You're muted.
Sorry, thank you. So let's go now to our polling question. Now that you have all this juicy information based on these test results and what you've been given, what do you feel is the most appropriate treatment for Jennifer? So you've got medical management, you've got functional endoscopic sinus surgery, you've got biologic therapy. So we're kind of, and not surprising, we're talking to an audience of surgeons, and we do love to do surgery. So we're seeing some fest dominance here, but I'm very interested in the those that chose biologics. So, and that's interesting because she has not had surgery yet. Let's go back to our slides. All right. So, Dr. Damask, can you tell us a little bit about surgery?
So we are all very familiar with functional endoscopic sinus surgery. And one of the best things for our patient is when we do functional endoscopic sinus surgery, in a few hours, we can take their nasal polyp score from whatever it was, an 8 or a 5, basically down to 0. And so in a short time frame, the patients can have rapid improvement in their symptomatology. And there are a lot of quotes out there about the recurrence rate after sinus surgery. And I think we're all familiar with that DeConde article from Laryngoscope a few years ago that quotes about 40% recur at 18 months. However, that just means that there was some regrowth, but not necessarily that those patients had to undergo revision surgery. There was another study that was done out of the UK, headed up by Claire Hopkins, that followed a cohort of patients in the UK for 5 years and looked at really what was the revision rate of surgery after a primary surgery for nasal polyps. And that was more about 20%. Also, we do know things that can predict the possibility of recurrence is the higher that T2 signal is. And so if that T2 signal is higher, like if we saw something like eosinophil aggregates on pathology or significant tissue eosinophilia or even comorbid asthma, those are the patients that are more likely to have recurrence. This is, again, that Galen network that Dr. Naclerio referenced earlier, and it's basically 9 different sites in Europe. One of them was in the U.S. in Philly. Not surprising because of Elena, but they followed CRS patients over a period of time to foster some information for trying to phenotype and endotype patients and get more info for research. And these patients in this network, it was almost 1,000 patients. It ended up being about like 800 or 900. They typically were treated with nasal saline irrigation, topical steroids, and oral corticosteroids, as we all tend to do, but found about 46% of the CRS with NP patients in this cohort ended up having some form of surgery. And then at the bottom, we again have that reference to the DeConde article with a 40% recurrence at 18 months. So when we have had these patients in the past who typically had recurrent disease, and we kind of kept rinse and repeat, where we were doing saline, we were doing topical steroids, maybe oral steroids, patients failing, go back, do surgery. And when that repeating cycle wasn't necessarily working for some of our patients, we didn't have other things to offer them in the past, unless maybe they had AERD and they could undergo aspirin desensitization. But for the most part, we had those options and didn't have other things. But now, as with various research that have been done, we have learned a lot more about T2 inflammation, and there are now different targets in that cascade that we're able to narrow in on and shut down and try to cut down on the T2 inflammation and hopefully help our patients. So some of these things have already been out for asthma. Some are recent for nasal polyps. But this is a nice, I think, graphic representation. It's simple and it's easy for us as otolaryngologists to kind of follow the immunology. So if you look up at the top, you have your respiratory epithelium, and that respiratory epithelium normally is nice and tight, not leaky, doesn't allow things in, but respiratory epithelium can become damaged and more leaky and allow different things to cross through, like viruses or bacteria or allergens. And once that epithelium starts getting pounded, it releases those alarmins, like Dr. Franzese talked about, the TSLP, interleukin 25, and interleukin 33. Well, there are now biologics that are currently undergoing phase 3 evaluation for asthma to target against TSLP, tezolizumab. Then after those alarmins get released, we can start to see the ILC2 cell stimulated and releasing cytokines, interleukin 4, interleukin 5, and interleukin 13. And as Dr. Franzese talked about, Th2 can influence that B cell to produce, undergo isotype class switching, produce IgE. There is now Omalizumab that is able to target IgE. Omalizumab has been around for 15 plus years, initially for asthma, then for chronic spontaneous urticaria, and recently for nasal polyps. IL-5, basically, like we heard, tells eosinophils to live long and prosper, and you can target free do an anti-IL-5 blocker with mepolizumab, or you can block the IL-5 receptor with benralizumab, and both of those are approved for asthma. Recently, mepolizumab approved for nasal polyps, benralizumab still undergoing trials. And then there is dupilumab that blocks the IL-4 receptor alpha, and that shuts down IL-4 signaling and IL-13 signaling. And dupilumab approved for asthma, approved for atopic dermatitis, and then recently approved for nasal polyposis as well. So I think this is a really nice diagram that kind of shows us all the immunology and then shows the different biologic targets superimposed on it. Euphoria is a group of clinicians in Europe from different specialties that had gotten together to give us some recommendations on when might we consider using biologics in CRS with NP patients. And basically, patients had to have evidence of bilateral nasal polyp disease. And then the criteria got broken down into whether this is a surgery naive patient or a patient who has had surgery before. A surgery naive patient is going to need to have 4 of the following criteria below met. A previous surgery patient needs to have 3 of the below met. And those criteria include evidence of T2 inflammation, needing oral corticosteroids 2 or more times a year, significant impairments on their quality of life, loss of sense of smell, and presence potentially of comorbid asthma. And so if we do look at wanting to add on therapy for patients with CRS with NP, what is currently available? Well, first, dupilumab was approved in June of 2019 for add-on maintenance therapy for CRS with NP that is currently uncontrolled. It is an IL-4 receptor alpha blocker, which blocks IL-4 and IL-13 signaling. It's dosed at 300 milligrams sub-Q every 2 weeks. Omalizumab was approved last year at the end of 2020. It blocks IgE, and it's an add-on maintenance for adults who have failed with nasal steroids for nasal polyps. Its dosing is based on weight, and so it will depend. They can be dosed between every 2 weeks or every 4 weeks, and the dosing can be anywhere from 75 to 600 milligrams. It just depends. The average, I think more than 90% of the people in their trials were 300 milligrams a month. Then mepolizumab is the newest one to be approved for CRS with NP. It's an anti-IL-5. It was approved in July of this year, again, as add-on maintenance for adults with inadequate response to topical nasal steroids. It is 100 milligrams sub-Q every 4 weeks. And then ongoing study is for benralizumab, which is an IL-5 receptor alpha blocking agent. Their trials are ongoing for phase 3. So I think this might be a nice time for us to look at some clinical stuff, as that's a lot more fun for us than hearing about all these studies and data. So Dr. Naclerio is going to talk to us about another case.
Thank you for setting the stage for these biologics.
Hi, I'm Eric. I'm 46 years old and I've had asthma pretty much all my life. Fortunately, it's been pretty well controlled by my inhaler. I mean, I can't remember the last time I needed to use my rescue inhaler. However, a couple of years ago, I started having a hard time breathing through my nose, and my doctor had me try a nasal spray, but that didn't help much. It got so bad that oral steroids were the only thing that made the congestion go away. They would help for a while, but then a few weeks later, the congestion got worse again. I kept waking up at night because my mouth would get so dry from not being able to breathe through my nose. And then I'd be sleepy during the day because I wasn't able to sleep at night. It started to affect me at work and made it hard for me to communicate with clients. So I went to speak to a specialist. I found out from the specialist that I had nasal polyps. And she told me I was a good candidate for surgery. And I figured I'd get the surgery and get rid of these things. I was told that there was a chance the polyps would grow back, and was prescribed a nasal spray after the surgery to try to keep the polyps from growing back. Unfortunately, they grew back pretty quickly. And here I am only 6 months later, and I'm just as congested as I was before. I'm a little frustrated because I thought it might be a few years before they grew back. I don't really want to go through the surgery again if they're just going to keep growing back. Unfortunately, I'm allergic to aspirin. It always makes my asthma worse. So I can't take that for pain relief, even if I did have surgery again.
So just to summarize again, you could hear this gentleman having lots of problems, right? He's had asthma, which we talked about as a very important comorbidity. He's got just had surgery, and it's grown back in an incredibly short period of time. He also has the aspirin exacerbated respiratory disease, which is a tremendous player in terms of the quick recurrence of disease from that. He's just using a nasal steroid spray at this point, which is not doing enough, and he seems to have his asthma well under control. His physical examination, his vital signs are pretty clear, but when you look in his nose, even with the otoscope or nasal speculum, you can see the polyps already. So they're large. I just wanted to highlight one very important thing, and that is this aspirin triad. I mentioned it before as a comorbidity. Um, you might have heard of it as Samter's triad years ago. It's got a marked hyperplastic pansinusitis. They're very recurrent, eosinophil rich, lots of mucus production, and their sense of smell is very much decreased. They also have asthma, which tends to be quite severe, unlike our patient, and lots of mucus and airway hyperreactivity. These people can't take any of the COX-1 inhibitors without going into response. Most people diagnose it by history because you don't really want to give somebody an aspirin trial to find out if they're allergic. They tend to tolerate the COX-2 inhibitors fairly well. So Eric underwent some tests. As we said, he had his endoscopy, and you could see the polyps coming down to the inferior border of his turbinate, and they're large. He had a quality of life test, the SNOT-22, which is he's got extremely elevated score. So now let's ask you a question. And based on Eric's medical history and symptoms, what would you recommend? The answer seems fairly clear from the audience that they would like to try some of those nice biologics that Cecilia told us all about from that. Back to the slides. So what I would like to share with you now is some of the clinical data that got the approval of these biologics. So it's nice that we know where they work, but where the rubber meets the road is, do they make a difference? So we'll start with dupilumab. These were all sort of double-blinded studies where they had a maintenance dose of intranasal steroids, and then they were randomized to dupilumab or to placebo injections. The two key endpoints are the nasal polyp score, which we won't go into, but these were all very large polyps that were entered into it, like the polyps that you saw in the first picture, as well as the description that was given. And then the congestion, which is the primary endpoint. And these were two endpoints that were done. There's two studies. One lasted for 24 weeks, and the other lasted for 52 weeks. So if we stay with the top left and the nasal polyp score, and you look at the primary endpoint at 24 weeks, you see that the polyps shrink very rapidly, and that at 24 weeks, there's at least almost a two-score difference between that. Now, if you stop this, you see that the polyps start to regrow, even though they're maintained on the intranasal steroid. And the same is true for the congestion and below. So what you're seeing here is that these are great anti-inflammatory drugs. It worked, but once you stop using it, just like with an oral steroid, the inflammation returns from that. So the question is, how long do you need to keep people on these for a prolonged period of time? Another very important outcome in this was they looked at two things. They looked at the need for surgery during the 52-week trial, as well as the need for a course of oral steroids during 52 weeks. So if this was primarily driven by the courses of oral steroids, but as you've heard, it doesn't take much oral steroids to put you at significant risk for a lifetime. So you can see that as time went on, that about almost 42% of the people on placebo required either surgery or a course of oral steroids. This was compared to the people on dupilumab, where it was 12.5%. So it was a highly significant difference from that. So it was preventing surgery as well as reducing the exposure to oral steroids. As with any study, there are side effects that are looked at from that. I would say that one of the things that to me has always been important when you think about safety is it's not just the data you see here is from the 2 studies that were used for approval, but this drug in the same dosage has been used for atopic eczema and asthma. And so the number of people exposed to it is much, much greater. The biggest problem is usually the injection sites from that they have. And you can see a scattering of other things. And Christine is going to talk about the studies for omalizumab in nasal polyps.
So for omalizumab, for nasal polyposis, similar to what we just discussed for dupilumab. So, and all the ones we're going to talk about are randomized, blinded, placebo-controlled trials. They use central readers for their nasal endoscopy. The interesting thing is some of the difference. So with a dupilumab study, they did require either a course of systemic corticosteroids or nasal surgery within the past 2 years, or you had to have a contraindication to one of those two. The omalizumab study was a little bit different because they did not have that requirement. There was no requirement for prior surgery, and there was actually no requirement for systemic corticosteroids prior to enrolling in the trial. And that's going to be even different from the next study we're going to talk about, MEPO, where everybody had to have surgery. So everybody's kind of looking at different populations here. With Polyp 1 and Polyp 2, these were 48-week and 52-week trials where patients were given omalizumab based on their IgE level and their weight. And most of the patients shook out to either be 150 every 4 weeks or 300 every 4 weeks. And you'll notice, similar to the dupilumab graphs, we're looking first at nasal polyp score. And you'll see actually pretty quickly these biologics have an effect. So as early as 4 to 8 weeks, you start to see that separation between the treatment group and the placebo group. Now, their response was not quite as robust. You'll notice that they decreased with a score of about 1, but they did have statistically significant improvement in both trials. Again, looking at slightly different populations. Looking at their efficacy of nasal congestion score. Now, again, every trial did things a little bit differently. For the Dupi trial and for the omalizumab Polyp 1 and Polyp 2, they both used 0 to 3 scales rating nasal congestion and other scores. The MEPO trial used a 0 to 10 visual analog scale, so we've got to make things complicated, but similar to dupilumab, they looked at nasal congestion, and you'll notice that really early on, again, like 4 to 8 weeks, we start to see statistically significant improvement in both treatment groups compared to placebo. Now, you do notice that placebo does improve as well. You have to remember in these trials, patients are on standard of care background therapy, which is mometasone, 2 sprays twice a day. And I know this is shocking, but when you take your medicine, sometimes it works and sometimes it helps you. So that's why we see some improvement in the placebo group too, because they're required to take their medication. With omalizumab and looking at their safety data, omalizumab is probably the granddaddy of the biologics. It has been out by far the longest. And so it had several other trials for asthma. It also has an indication for urticaria. And looking at the safety signals for this particular data, there were no new safety signals. the adverse events as well as the most common adverse events are relatively similar between the placebo and the treatment group, and there are no new, indications or no new adverse events compared to the other trials. Again, very commonly are injection site reactions, but they may have had some asthma exacerbations, sore throat, headache. And then nasal polyps doesn't mean omalizumab gave them nasal polyps. It just means they had an exacerbation in their nasal polyps. So now we'll go back. I think we're going to the MEPO data, correct? Yes.
Thank you. And as was pointed out, MEPO is an anti-IL-5, and IL-5 is a key player in the life of eosinophils. I like this slide, which came from their from this study that was approved for the indication for chronic sinusitis with nasal polyps. This one is a little different. So we're looking here at nasal polyp scores, and on the red towards the top are the results for MEPO, and those for going down in the gray are for the placebo. So again, there was either they were on a background of intranasal steroids, then they were randomized to either anti-IL-5, or they were going ahead and given placebo. So what you see here, and in a quick glance, you can see that many more people had a shrinkage of their polyps on the left side and on their congestion score on the right side on those groups that were on the active medication. But I'd like to point out a couple of things that I think are very important as clinicians from that. So if you look to the very far left, you see that those are people worsening. So 20-something% of the people with on MEPO got worse during the trial, and 30% or 27% had no change. So their polyp scores didn't change in about half of the people from that. The other thing is that you can see that these polyp scores do have their problem, but you can see that there were some people that had a dramatic response to the placebo. And I think these are all kinds of things that we need to sort of keep in mind as clinicians from that. This is similar, but this is just the need for surgery. And as was pointed out, all these people had to have surgery prior to going on or entering this trial. And you can see those on placebo in the red had many more surgery interventions than those that were on the MEPO from that. And this is highly statistically significant. So when it works, it's very helpful to the patients. Its safety profile, again, is relatively safe. Large database on this agent used for the treatment of asthma from that. And there's not much of a signal or anything new that came up in the safety data. So how do we select a biological? And where people are asked for opinions, and that's exactly what this is. Unfortunately, we don't have trials comparing A to B or to C or any other combination of medical treatments. So, but this was sort of the best guess of a bunch of active clinicians. So you want to confirm the diagnosis of uncontrolled severe chronic rhinosinusitis with nasal polyps. You'd like to check for these comorbidities. Asthma and aspirin sensitivity are very important, giving that type 2 inflammation. They talk to check for type 2 inflammation. There's not too many clinicians that actually go in there and endotype or look at secretions for the results. People do look sometimes at IgE in the blood and eosinophils, which can give you a hint. You want to inform the patient on treatment options, perspectives, and risks. You want to make decisions on surgery or biologics with an informed patient. And you want to select biological drugs, noting limitations of applicability for specific drugs. So chronic rhinosinusitis with nasal polyps and asthma they believe was a collaborative disease, and that it's often to get an asthma specialist involved on people that have chronic sinusitis with nasal polyps, specifically with the comorbidities from that. So we have a polling question. If biologic therapy is chosen for Eric, how long would you wait before evaluating the response? And I'm going to leave the answer to Dr. Damask.
All right, so we'll bring up the next slides. And as Dr. Naclerio told us, the euphoria guidelines are really opinions of a group of clinicians. And euphoria recommended reassessing after 6 months how response is. Other groups that have given opinions, like EPOS, they recommended evaluating treatment after 4 months, but this example here is Euphoria. And Euphoria recommended assessing after 6 months and recommended that there should be improvement in at least one of the following, that there should be some improvement in anosmia, like scoring something on an upsit, improvement in nasal polyp score based on endoscopy, or nasal congestion score, or potentially at least an MCID improvement on SNOT 22 of at least 8.9, or VAS. And VAS is that ruler with things being not so bad, being as worse as they could possibly be. Visually on that ruler, where does the patient put themselves? And if there really is no improvement in any of those things, Euphoria said after 6 months, you really should stop that biologic and either do surgery or potentially switch to a different biologic, because maybe they would respond to something different. However, if there is improvement in at least one of these things, and the patient also says, yeah, I'm feeling better, then continue with the biologic. Whereas if you see objective improvement, but the patient says, yeah, things really aren't getting better, then potentially consider salvage surgery or doing a burst of steroids, and then potentially continuing with the biologic. And then Euphoria also recommended that you follow up with the patients again after a year of treatment, and again, look at similar things. But this time they say that really the nasal polyp score should be down to less than 4 on both sides. Their nasal congestion score should be less than 2. Their VAS, that ruler thing, should be less than 5. And SNOT 22 overall should be less than 30. And that most importantly, that the patient has not needed any systemic steroids or no longer needs surgery, then great, continue with a biologic. But if really after 12 months, these things are not met, then either do a different biologic or go on and do surgery. And so that's our guidance at this point. So I'm going to turn over to Dr. Naclerio to kind of wrap up all the things we have discussed and learned this evening. You're on mute.
Hopefully everybody learned a lot through the evening program. Nasal polyps pose a significant impact on the quality of life. And as you saw, they cost the country and the healthcare system an enormous amount of money. The basic treatment of intranasal steroids and endoscopic sinus surgery with occasional bus is basically the foundation of conventional treatment. And if you were to look at some numbers, you might see that we start out with maybe 30 million adults that have chronic rhinosinusitis with nasal polyps, and perhaps we operate on 200,000 a year. And of those, about 20% are recurrent disease. So remember, when you're talking about the standard treatments, they really do a great job for the vast majority of polyps. It's these severe disease with these large polyps, major impacts on quality of life that are really where we start to talk. The other thing which I find very fascinating is the oral steroids, and that they should be used sparingly. I'm struck by how small a lifetime amount of steroids can lead to adverse consequences, and that's made me even more conservative in my approach. The type 2 inflammation and the understanding of the inflammatory process has just been spectacular, and hopefully you've seen it and how we now have agents that go ahead and block parts of that inflammatory process. And even more important, by blocking parts of that, we get good clinical relief for our patients from that. It'll be interesting to see in the future that half the people with chronic rhinosinusitis without nasal polyps are type 2, where they maybe benefit from some of these biologics, particularly in the severe disease people. You saw that allergies, asthma, and aspirin sensitivity are common comorbidities. The 3 biologics improved both symptoms and the physical shrinking of the polyps. And you got a group's opinion from Europe about which directions and which biologics to evaluate. But clearly, there's lots more studies to go. But I think you've seen now that these biologics are really a big game changer in how we approach this disease of chronic rhinosinusitis with nasal polyps. And at this point, we'll start to answer questions, and I hope you fill up the question box. So the first question I'm going to ask Christine to take a look at. In a patient like Eric, would you do IgE or EO tests?
So just as a reminder to everybody, Eric was the third case. He was the patient that had he had a FES, and he had recurrence of his polyps very quickly. So that quick recurrence is like a bad prognostic sign, but probably would be a good indicator for our biologics. So in him, what do you want to look for? Like ideally different biomarkers. So in a patient like him in my practice, I would look for their peripheral eosinophil levels, but he's had surgery before, and it would be interesting to obtain his path results to see if the pathologist commented on any tissue eosinophilia in any specimen that was sent during his surgery. Now, that can be a little challenging because not all institutions and not all pathologists are willing to count eosinophils per high-powered field or comment on them. It's certainly not standard. And most of the pathologists at my institution will do it, but not all of them. So just because his path report doesn't show eosinophils might not necessarily actually reflect it. It might be nice to get those slides and see if you could get them reviewed at your institution, if your institution will do that. So peripheral eosinophils, tissue eosinophils. And yeah, I would get an IgE level, particularly if you're considering like, Omalizumab. It also might be nice. I'm trying to remember I believe he did have asthma and AERD. So it'd be nice to know if he ever underwent aspirin desensitization. I don't believe he did. In addition, you might consider getting a CAT scan if you don't have the operative report. If you do have the operative report, you might be able to assess like if all the sinuses were addressed. And then certainly there's a discussion of like the completeness of the FES. If you can't tell from nasal endoscopy alone, if he has extremely large polyps, a CAT scan may help you see, are there still ethmoid partitions? So there's a number of things that you could do, but definitely for biomarkers, I'd look for tissue eosinophils, IgE, and blood eosinophils as well. Cecilia, is there anything different you would do?
No, I agree. I mean, I would do a CBC with differential, and I would do a total IgE. And, definitely want to point out that just because the eosinophil level falls within the normal range at your institution, that doesn't necessarily mean that it is insignificant. Because a lot of laboratory values will go up to 500 to be normal for EOs, and that would be really high to me.
Yeah, that would be extremely high. And the other thing you have to take into account is if the patient has any recent systemic corticosteroid use, because that will really drop your eosinophil level. In addition to daily corticosteroid use, that will really plunge your levels, and you'll artificially have a lower level when, if off of an oral steroid, they may have a very high level. So you want to look not just at the percentage and the absolute values, become familiar with what is truly an elevated eosinophil level and not just what your lab says.
Very good. I would echo about what was said about the CT scan, because I think the question is everybody deserves one good surgery. And the question is, did they actually get that good surgery? And you can see some data out of Rod Schlesinger and Peter Walmall that sometimes bigger operations lead to longer and better results over time. Let's see, here's a question. If you have a patient who is a candidate for surgery, should the risk and benefits of biologics be reviewed during informed consent? Who would like to begin?
So, yes. so yeah, just like if you were going to do surgery, now I don't do informed consent for biologics. I mean, I do go over the risks and benefits and lay out what your course is, similar to what you would do with surgery. So if you're going to plan on doing surgery with someone, you're going to go over the risk of CSF leak, you're going to know the risk of orbital injury, all those things that go along with it, but you're also going to lay out expectations for the patient. After sinus surgery, you're going to have to do rinses. You're likely going to put budesonide or whatever your flavor of steroids that you like in your rinses. You're going to rinse like X number of times a day, and here's your expectations. Same thing with a biologic. You would lay out, okay, so generally the main risks are injection site reactions. There are other ones specific to certain biologics. Likely fatigue is very common. If you're thinking of MEPO, you may want to counsel if they've had zoster before, that they may want to get a shingles vaccine before then. If you're talking dupilumab and they have any kind of eczema, they'll likely have more conjunctivitis. The conjunctivitis by itself wasn't seen elevated in the nasal polyp trials, but it's a potential side effect. You're going to talk about like elevated eosinophil levels that happen when you first start dupilumab. So there are a number of specific things. You're going to talk about Omalizumab. They may get their first 3 injections in the office and wait to be observed. You can actually do all of these biologics, including Omalizumab, at home now. Omalizumab is approved for home use in appropriate candidates after the 3rd dose. But you're going to lay out your expectations. Like, I'm expecting to see a response in X number of months, and we're going to reassess at that time. Dr. Damask, do you have anything?
I agree. I mean, you want to just kind of like how you do for your immunotherapy. You give them informed consent, tell them, the risks associated with it, but then you want to tell them, what are other things that they may be responsible for. So if you do end up doing a specialty pharmacy, what is the patient going to have to do to be able to get that drug? Or maybe if you only do drugs in-house, then you have to explain that process to the patient. So I think it's very similar, like how we do for immunotherapy, and go through that and go through reasonable expectations with the patient.
I would just like to those answers are great. The question, though, is maybe a little bit different. So in other words, you see a patient and maybe in your mind, you think that surgery is the way to go, do you then tell them as one of your alternatives is take a biologic? I think that is kind of part of the question, as opposed to just that you're giving them a biologic and getting consent.
I mean, I would. I mean, it is that shared decision making with the patient. You want to give them all the options. I mean, option is you could do nothing and still have polyps in your nose. You could continue with medical management. We could do steroids, but there are these side effects that go with them. You could do surgery, or you could potentially do an injection, an add-on injection, or we could do any combo of these above things. So I think it's part of the shared decision-making process.
Yeah, I agree. I mean, if you're going to talk about options, just talk about all of them: surgery, biologics, other, the exhaled delivery system. There's steroid-eluting stents. Like, you can go through all the different options depending on what you have available in your practice.
Yeah, that would be a little bit of a question, these things are expensive, and, does every insurance company cover their cost, so that it really is an option for the patient? And do you feel so strongly that, some of these patients, I would think, are so well handled by, traditional surgery followed by, from that? Because if you look at the 5-year recurrence or need for another surgery is 20%, that meant that 80% of these people with surgery and a steroid actually do quite well. And it's a good alternative. So I wouldn't give up on the traditional, but I think it's a beautiful option for our severe patients and those that have failed the usual way that we do things. So here's a question. Any experience with biologics in patients who are steroid naive, i.e. with asthma, aspirin sensitivity, etc.?
So, I mean, steroid naive, meaning that they have never had to be placed on systemic steroids, then in my mind, they may not be a severe patient that I would be looking at a biologic. If they were steroid non-responsive, I also probably would not be thinking of a biologic, because they may be not T2, they may be more T1 or T3. But if they're asthmatic or aspirin sensitive, they probably are on some form of at least a topical steroid, if not a systemic steroid. So hopefully that is what you were looking for, but I'm not exactly sure. So hopefully that answers your question.
Yeah, almost every patient that I've seen that I've placed on a biologic has had at least one or more courses of some kind of oral steroid or injection for their disease. Including like a severe out of control type 1 diabetic. Like, he even got like crazy amounts of steroid and it was horrible for him. So I haven't encountered that unicorn yet, but they're probably out there.
Surgery naive.
Oh, is it?
Yes, surgery naive.
Oh, that
makes more sense. So
yeah, I would say that the only thing I would say, there are some people who have contraindications to oral steroids, so it does provide an alternative for that. And if you look at like the data from the groups, like say the dupilumab studies, what you see is that it's something like 80% of the people were on oral steroids in the 2 years before. So that meant about 20% of them didn't receive oral steroids in the years before. Some of them might have had surgery. But the answer is that, they did respond to the dupilumab, just like the ones that didn't.
So I've had a few surgery naive patients. By far, the bulk of patients that I've seen for biologic candidacy assessment have had one or more surgeries. I've had one patient who had 10. But I've had a few patients that have come out and that have said they didn't really care how horrible their polyps were. They were just too afraid of surgery, or they had a religious objection to it, or whatever. For whatever reason, they didn't want to. And I've actually had some extremely good responses in those patients, but by far and away, they're a really, really, really small majority. Cecilia, have you had anybody?
I have had a small number, mainly elders who really have not wanted to undergo surgery, but a small number.
Here's a question which I think I can guess the answer. It's coming. What is the panel's opinion regarding postoperative use of nasal sinus irrigations using steroids such as budesonide? Is one thumb up?
I believe that is considered to be standard of care by many people. So if you are able to get budesonide irrigation in whatever form, and I've seen all kinds of concoctions in like aerosol devices and compounded rinses, but I do think that the vast majority of otolaryngologists would put some budesonide, although I've seen some people recommend mometasone in their rinses. I think budesonide is probably considered standard.
I would agree from that. So we have uniformity with regards to that question. Here's one that will probably get a little different opinions. Do you ever prescribe these biologics yourself, or do you defer to allergists/pulmonologists?
I prescribe them myself. I prescribe them myself for all the indications for asthma, for atopic dermatitis, for hives. And I think that this is something that fits very well in our wheelhouse and fits very well for our fellow AAOA members who offer immunotherapy. I think this fits in very well. And I feel really strongly that this is something that we as a specialty need to know about and be able to offer patients so that we are offering them the full scope and they can get the most comprehensive care all from us and not have to necessarily involve a lot of other specialties. Yes, there are extreme patients that need multidisciplinary help, but I think that there are a lot of these patients that we are very well equipped to be able to offer these treatments to them. And I think Christine agrees with me.
Yeah, I would agree. I prescribe them too in my practice. I prescribe them for all their indications, all 4 of these. And I do think it is a very good thing to add to your practice once you become familiar with the prior authorization process. And generally the cost to the patient, I mean, there are a lot of ways to help access. There's a lot of foundations available. There are patient assistance programs because these medications can be expensive. And there are different ways to do that. The patient's insurance may require a specialty pharmacy. The patient's insurance, like I believe Medicare, correct, is buy and bill. So that will change how you can deliver the medication and whether they're eligible for at-home delivery for some of these medications. And then there are, if you have no insurance, I mean, I have some Mennonite families in the area, and I have twin brothers that both have severe polyps that didn't want surgery, who get their medication free of charge directly from the company. So there are different access routes available.
Christine, while you're on that, there was another question which said, can you go over the yearly cost of these biologics?
So each of these biologics, the cost will actually change every quarter. And it depends on whether the biologic has a specific like J supply code. If they do, it's considered, it goes through something called an average selling price, which is determined by the Centers for Medicaid and Medicare, correct, Cecilia? And they do that like on a quarterly basis, which is published on the CMS site. So you actually can see what the asking price of those drugs are. The dupilumab is different. It doesn't have a specific J code yet. So it has something called the WAC. It is WAC, which is the wholesale acquisition cost. Now, this particular cost is set more by the manufacturer and not by CMMS. You'll actually find that on their website. I just checked, and the last time they had updated it, I think, was the end of January. So they haven't updated it for the new quarters. But all these prices will change every quarterly. Omalizumab has been out the longest. The prices kind of range anywhere from like $1,100 to $1,500 for a dose. For Mepo, you're usually around 3,000-ish. I think Benra is 4,000 or 5,000. And then Dupy, I think for a month supply is about 3,700. Overall, the yearly costs for Dupy are by far the highest. But again, it depends on how you're using it. So again, this is off-label, but I use these in my practice. And I have many people that don't take them year-round. They actually get great responses. I have one patient in particular who just does his own thing. He'll use it for 6 months out of the year. He'll use dupilumab once a month, and that actually holds him at almost a grade 0 polyp score. I have had others. I've had one patient that I used omalizumab on. I used her as a patient case. She took 6 months of 150, and she didn't take any more, and she's actually been almost like grade 1 polyp score for 2 years off of treatment. So there's all kinds of, again, that's off label. And you should expect to them to be on it all year when you're looking at the average cost. But in reality, the cost to the patient and the payers may be different depending on how they respond to these drugs. But as a whole, Dupy is going to be by far the most. And then it goes down to OMA. But again, the OMA range, omalizumab, can be anywhere from 75 milligrams every 4 weeks to 600 milligrams. You know, you can give that every 2 weeks, I think. So it's like a huge, huge range. There's a big range in cost for omalizumab. So that by far has the biggest range of cost. It could be the cheapest or it could be the most expensive. You decide.
I think we've run through the questions. So if anybody's out there, it's time to start typing in your question. Does the panel like to make any sort of closing comments? The things that should be emphasized?
I would just like to say that it is definitely something that otolaryngology can do, and I think it is something that you can consider offering to the right patient. And if you're interested, you definitely can add it to your practice.
Yeah, I would like to echo Cecilia's points. I want to thank everybody for coming, but just really otolaryngologists, we're best suited to really give comprehensive care for chronic rhinosinusitis with nasal polyposis. And I think we need to take these in our wheelhouse. And if you don't use it, you'll lose it. So please keep that in mind, because we don't want to lose this disorder. We really want to be the shepherds of this disease.
Well, I'd like to thank the panelists who've been outstanding and the audience too for asking great questions. And thank you all. You're going to now be directed to the evaluation, or you can go claim your CME credits at www.integrityce.com/AAOA post-eval.